Hi everyone, welcome to Chest X-ray, the fundamentals. I'm Dr. Pathak. In the next hour I'm going to be talking to you about the basics of interpreting a chest X-ray. I'll start about how the physics works. Essentially, a chest X-ray is an X-ray image. The X-rays go through the patient, and if they go through less dense tissue, the impression or the shadow they make is dark. If they go through denser tissue, such as soft tissues, heart, skin, they become a bit more grey. If they go through very dense tissue, such as bone, the shadow they make is white. So when you look at this chest X-ray, you can see that the air in the lungs is dark, the ribs and the bones are white, and the mediastinum is also white. So, as a brief introduction, we're going to talk about the anatomy. We're going to look at normal anatomy and compare that to abnormal anatomy. We're going to have a look at the radiological anatomy. That's essentially looking at a 2D image and trying to interpret the 3D anatomy and the pathology. We're going to look at common or serious pathologies that you may come across when you are working, and I will talk a little bit about the approach to a chest X-ray. Now, this can be seen as an approach when it comes to an exam, where you go for the money, make the diagnosis, or if you're having trouble making the diagnosis, you can use the systematic review and go through each anatomical structure, trying to identify the abnormality. And of course, imaging will direct management. So that's why we do these things, because they direct management, and we'll talk a bit about management. We'll start with a quiz. So here is a chest X-ray. Here are the various different structures which have been highlighted in blue and red. These are mediastinal structures, and we're going to have an attempt at trying to identify what these structures are. So you're looking at chest X-ray. What do you think structure 1 is? It's blue, so that's a clue. It's got, it goes to the right side of the heart. It continues downwards. It is actually the superior mediastinum. 2 is the inferior vena cava, which connects to it. So what comes between them? The superior vena cava and the inferior vena cava. Well, between them come the right atrium. They drain into the right atrium. 4 is a continuation. You can't really see its borders on the chest X-ray, but when it's enlarged, it becomes more conspicuous. It's the right ventricle. 5, actually, you can see on the chest X-ray. It is the left lateral border of the mediastinum. It is, guess anyone? The left ventricle. Good, those who got it. 6 is a structure that comes off the left ventricle, and it comes all the way around. It's red, so that might give you a clue. It's an artery. It's actually a very big artery. It's the aorta, ascending aorta, becoming arch of aorta. And 7 is the pulmonary trunk. Following on from the anatomy of the mediastinum is the anatomy of the lungs. So from your anatomy, you should know that the right lung has 3 lobes, an upper, middle and lower lobe, and the left lung has 2 lobes, the upper and lower lobe. And this is where they sit on a chest X-ray. You can see the right upper lobe sits and occupies most of the superior half of the right hemithorax. The middle lobe occupies the lung, the area adjacent to the right heart border, which is here. Remember we talked about the right atrium. And the lower lobe of the right lung is very posterior, but a slip of it comes out anteriorly and sits over the right hemidiaphragm. The left lung upper lobe occupies lots of the anterior and superior lung, and the left lower lobe is tucked behind the left upper lobe, and therefore you can't really see it on a chest X-ray. Well, you can because it's behind the right upper lobe, but what you see on the 2D image is that it will sit on the left hemidiaphragm. So you need this anatomy, the anatomy of the mediastinum and the anatomy of the lungs, to place pathology. I mean, it's no good to just say that, you know, there's an abnormality of the lung. You should be able to say where it is. And one of the tools that we use to identify where pathology is, and actually to identify pathology itself, is what we call the silhouette sign. Now, I'm not particularly big on these sort of names, but the physics is important. So if an X-ray was to go through lung and go through heart to make a chest X-ray impression behind it, if a normal healthy lung full of air sits against a normal heart, then the difference between the densities is quite stark. It's crisp or sharp. You should be able to see the heart borders very carefully, because actually all that's sitting around them is air-filled lung. But if the lung becomes abnormal and starts getting filled with soft tissue like fluid, infection or tumor, then the difference in density is blurred. The heart border isn't going to look as sharp because the lung sitting against it is full of pathology. So you lose your lung soft tissue interface. And where that interface is lost will tell you where the pathology is. Let me give you some examples. So if there was some pathology in the right upper lobe, then the sharp border of the superior vena cava would be lost. If there was pathology filling up the air spaces of the right middle lobe, then the right heart border sharpness would be lost. If there was fluid, infection, pathology within the right lower lobe, then that diseased lung would be sitting on top of the right hemidiaphragm, and you would lose the nice, sharp, crisp border of the right hemidiaphragm that we're seeing here. On the left side, if there was pathology in the left upper lobe, then it would blur the aortic knuckle or aortic margin. And if there was pathology in the lingular segment of the left lower lobe, it would blur the sharp, crisp left heart border. If there was left lower lobe consolidation, then the left hemidiaphragm would not be seen as clearly as it is on this normal chest X-ray. So bearing that in mind, let's have another little quiz. Here is a chest X-ray, and the black is air in the lungs, the white is a mediastinum, and the white is also pathology. So let's look at the top left. White is pathology. It has obscured the right superior mediastinal border where the superior vena cava is. Which lobe of the right lung is that going to be in? That's going to be in the right upper lobe. If there's pathology here, which is depicted by the white, what is it obscuring of the mediastinum? It's obscuring the right heart border. So the pathology will be in the right middle lobe. Here we have pathology in white, which is obscuring the right hemidiaphragm. Note that the right heart border is still seen, but the right hemidiaphragm isn't. Therefore, the pathology is in the right lower lobe. Here we have pathology obscuring the aortic knuckle, which should be seen, so you can see it on the other ones, this nice little knuckle here, the aorta. So it's gone here, therefore the pathology must be in the left upper lobe. Here there's an abnormal white shadow adjacent to the left heart border and obscuring it, therefore the pathology is in the left lingular. And lastly, you can see that the left heart border is nice and crisp, but the left hemidiaphragm has been lost, therefore the pathology must be in the left lower lobe. So yeah, might be a bit tricky to take on board immediately, but actually just have a review of it and it starts to become easier the more chest x-rays you see. Time for another quiz. Here's a chest x-ray, here's your guide on the right. Which lobe is the pathology in? Have a think. Let's identify the pathology first. It is here, all this grey-white stuff here, which should otherwise be in dark lung. Which border of the mediastinum is it obscuring? It's obscuring the right middle lobe. So, sorry, the right heart border, so therefore it is in the right middle lobe. That's right middle lobe consolidation. So this is consolidation, and it is centered over the upper third of the right lung, and you can't really see the superior mediastinum anymore because that diseased lung is sitting right up against it, and the x-rays see them both as the same density and therefore will not make the differentiation as clear as it should be. Where is the pathology? Let's give you a little clue. Anyone? It's right upper lobe pneumonia. Okay? Oh, now where's the pathology here? Well, let's have a think. This is the chest x-ray. We can see that the pathology is centered over here in the right lung at the bottom. We can see just about the right heart border, but can you see the right hemidiaphragm? I can't see that crisp, curvilinear right hemidiaphragm. So where do we think the pathology is? Right lower lobe. It's right lower lobe infection. So right lower lobe abnormalities obscure the right hemidiaphragm. Okay, how about this one? This should be fairly simple. Where is the pathology first? Okay, it is here in the lower segment, lower region of the left lung. And which border is it obscuring? Well, it's not obscuring the aortic knuckle, nor is it obscuring the left hemidiaphragm. It's obscuring the left heart border, therefore it is pathology in the lingular consolidation. Now what about this? Where's the pathology here? Well, there's not always just one pathology, there's two abnormalities here. There's shadowing here in the right upper aspect of the lung, and the shadowing here in the upper aspect of the left lung. This is obscuring the right heart border a little bit, and this one's obscuring the aortic knuckle. So these are both going to be bilateral upper lobe pneumonia. So the pathology is in the upper lobe, because it's obscuring the superior mediastinum on the right and the aortic knuckle on the left. Okay, so let's look at the money approach to a chest x-ray. First things first is that you make sure that the name corresponds to the patient. I know it seems a fairly simple thing, but believe me, there are many cases where doctors, healthcare professionals diagnose the wrong thing on the wrong patient because they haven't performed this basic check. Next is lines and tubes. You have to make sure that the lines and tubes are in the correct position. Then you look at the chest x-ray and spot the abnormality. If you've spotted it, describe it. Look for other associated abnormalities that may support your diagnosis or even refute it. Try and give a sensible differential and propose management. Remember, common things do actually occur commonly. Now, if you can't see the abnormality, then revert to the systematic approach. This is the basics of the money approach, which is name, lines and tubes. And then what you do is you look at the individual structures individually. So lungs, look for airspace opacification, pneumothorax. Pleura, look for effusions, look for thickening, look for pneumothorax. Look at the bones, look for fractures or rib lesions that could be metastases. Look at the mediastinum, comment on the heart size, look at the contours of the mediastinum. Look for air within the mediastinum, which is a pneumomediastinum, which might indicate esophageal rupture. And then look for abnormal air or abnormal shadowing. Abnormal air occurs in surgical emphysema. You also get air under the diaphragm pointing to hollow organ perforation. So let's go through these things. We've done the name. Next are the lines and the tubes. Remember, in a hospital setting, and in particular a critical care or ITU setting, there are lots of lines and tubes. They are there for a purpose. If they are used incorrectly, it can be fatal. So you must account for every single line, and you must trace each line from beginning to end. Shall we look at some examples? So, what is wrong with this chest x-ray? Look at the lines. What line do you see? You see this line here, going up from the upper airway, going down. This is an endotracheal tube. Now what's wrong with it? Well, look closely. This is the trachea. This is the air within the left main bronchus. The endotracheal tube is actually only in the right main bronchus. It should be in the trachea, but it's in the right main bronchus, and is occluding the left main bronchus. So the line is in the wrong place. Let's look closer. You can see how it veers towards the right. It's intubated the right main bronchus. Here's another more striking example of the wrong bronchus intubation, where the right main bronchus, where the endotracheal tube has gone into the right main bronchus and occluded the left main bronchus, and the left lung has, as a result, collapsed. So you've got an aerated right lung but a collapsed left lung because the endotracheal tube has occluded the left main bronchus. So, real life example. Do we start the nasogastric tube feed? What do you think? Yes or no? Well, let's go back to basics. We've checked the name. Let's look at the lines and tubes. How many lines can we see on this X-ray? You can actually see 4. One here is of no consequence. It's just a line, perhaps an ECG lead. I think there's a sort of connection here. The second line is this ECG line going across, obscuring the image, but for us, we know it's outside the lung, so of no significance to us. There is the endotracheal tube. You can see the two parallel lines of the endotracheal tube. It's within the trachea, not in the right main bronchus or the left main bronchus. And the tube of interest is this long, curvy linear tube going all the way down into the right lung. So what's happened is this is a nasogastric feeding tube. It should go into the oropharynx, down the esophagus, and the tip of it should be in this gas-filled viscous under the left hemidiaphragm, which is the stomach. Unfortunately, this has gone in the wrong place and it's gone down the right main bronchus, and now the tip of it is here, and unfortunately they fed the patient and this was a result. Literally, they are putting feed into the lung and massive infection, aspiration, went over to the other side, and the patient unfortunately passed away from severe aspiration pneumonia as a result of incorrect nasogastric tube feeding. So just an example of why checking the lines and tubes is so important in a hospital setting. Okay, let's start. Should we start the feed? Let's have a look at the lines. So take a deep breath. There's a lot of lines on here. A lot of them are really of no consequence to us. So again, these ECG leads over the patient, you can see they're clearly going outside the lung, so not of any importance to us. We have this right internal jugular line within the superior vena cava. We've got an endotracheal tube. But remember, I asked, should we feed the patient? Well, where is the nasogastric tube? Can anyone see the nasogastric tube? The nasogastric tube is here. It's curled up in the oropharynx and the nasopharynx. We thought it went down easily, but all it did was curl up here. So if you start feeding the patient, all you're going to do is going to get the back of your throat filled with feed. It will be aspirated and the patient will have a pneumonia, which I think he already has actually. Let's look at that more closely. There we are, magnified. The nasogastric tube curled in the oropharynx. So important to check where we're going, okay, where our tubes are. Why is this next patient got an arrhythmia? Well, the red arrows are pointing it out, why he's got an arrhythmia. Let's just have a look at the tubes first. Here's the endotracheal tube, it's in the correct position. Here's a nasogastric tube, it's not going down the left or right main bronchus. We can't say where it is exactly, but it's probably within the stomach. We just need to look at the end of it. What this patient actually has is an internal jugular line, which should really have its tip in the superior vena cava, but unfortunately it's too long and it's curled up within the right atrium where the sinoatrial node is, and it's basically irritating the sinoatrial node, and this patient is having an arrhythmia. This needs to be replaced or retracted or cut to the right size, and it's important for us to identify these tubes because, you know, an arrhythmia can become nasty, can become VF. Let's now talk about density in the lungs. So we're not talking about mediastinum now, we're talking about increased density within the lungs, which are majority air-filled, and that's why they look so translucent or dark on a chest x-ray. But when those air spaces fill up with stuff, then they become a lot brighter or lighter, and we need to figure out what that stuff is sometimes, and sometimes we can tell based on a chest x-ray. Airspace opacification is normally or can be a result of pus filling in the airways. You know, you have an infection, a massive inflammatory response. You have the byproducts of inflammation and infection, essentially pus, and these fill the air spaces, these little balloons of air, the alveoli, and it looks dense. Fluid can fill in the airways, and fluid can also fill in the pleural spaces. Fluid fills in the air spaces mainly as a result of pulmonary edema. Pleural effusions, soft tissue lesions can be deposited in the airways and the air spaces, particularly in the air spaces. Cancer, metastases, primary lung tumours. Look for associated features and always correlate clinically. And that means treat the patient, not the pictures, not the x-ray. So if you get an x-ray report which doesn't correlate with what the patient is exhibiting clinically, then review the chest x-ray or even review the patient. But you know, the chest x-ray should be an adjunct to your clinical examination. Pus is essentially infective consolidation. As I alluded to before, the byproducts of inflammation and infection result in airspace opacification. This normally has a lobar distribution, not always, but at the beginning you have patches of infection, and then when it becomes quite severe, it occupies a lobe. And anatomically, there's unless it's treated, it takes some time for it to spread from one lobe to another. So if you've got abnormality that has a lobar distribution, think about infection, as opposed to edema, for example. Pulmonary edema affects all lobes. Correlate clinically. If the patient is septic and there's an airspace opacification, it's probably infection. Repeat the chest x-ray after appropriate antibiotic treatment, and you should see a resolution. And look for air bronchograms. Now, what are air bronchograms? Well, it's the silhouette sign again. So if you've got an airway like a bronchi or a bronchiole, and you've got pus within the alveoli that airway supplies, then you're going to get air in the airway accentuated by pus in the surrounding airspace or surrounding alveoli. This isn't normally the case because both airway and alveoli contain air, so you can't see the difference in the two. But if you've got pus in the alveoli, then you will see the air in the airway, the bronchi or the bronchiole, much more clearly. So I'll give you an example of that. Air bronchogram. Look here, you can see the whole lung, well, a lot of airway surrounded by pus, filled with pus, and the airways are these streaky air density areas. It's the airway outlined by pathological filling of the alveoli. This is what they look like. You can see a branching structure, which is the airway, and it's accentuated by pus within the air spaces. So it's a branching structure. So if you see a branching structure on the background of increased density, it's an air bronchogram. It suggests infection. Here is another example, a branching airway with pus in the surrounding alveoli. Here is a right upper lobe airspace shadowing. So again, it's a lobar distribution. It hasn't quite crossed the fissure into the right middle lobe and right lower lobe. So the airspace is confined to the right, the airspace opacification is confined to the lobe, and it suggests infection. And here we have a left-sided large pleural effusion. Another thing to think about is when you're thinking about pus and infection is that if you treat the infection, then the chest x-ray abnormality will resolve. So the follow-up film or the previous film is incredibly important. Here's an example. There was this chest x-ray which had this opacity here just next to the left hilum. It became bigger, and there was a concern that it could be cancer. But we treated with antibiotics, and then it started getting smaller again. So if it's reversible with antibiotics, it's likely to be infection. You know, you don't want to give a patient a cancer diagnosis if they haven't got cancer. The caveat is that the two aren't mutually exclusive. You can have cancer and an infection, so we want to check the chest x-ray after treatment to make sure it's completely resolved and there's no residual lesion after antibiotic treatment. So now we'll talk about another cause of airspace opacification and pleural effusions, and that's pulmonary edema. Pulmonary edema, I mean, as you probably know, can be cardiogenic, where you have increased hydrostatic pressure, secondary to cardiac failure or volume overload. And it can be non-cardiogenic, where you have decreased oncotic pressure, increased capillary permeability due to lung injury, often seen in ARDS, where fluid enters the alveolar space. Let's talk about cardiogenic pulmonary edema first. You have increased hydrostatic capillary pressure. This happens in heart failure, where your venous return is impaired because your heart can't pump the blood out quickly enough. You can see on a chest x-ray you get increased cardiac size, you get airspace opacification, you get something called septal lines, which we'll talk about. There's upper lobe blood diversion, so blood is diverted to the more aerated portions of the lung, which are the upper lobes, and eventually the fluid leaks out and you get pleural effusions. Let's have a look at an example. The heart size is enlarged. Okay, it's more than 50% of the cardiothoracic diameter. You've got alveolar edema with their bronchograms. So this is a beautiful example of pulmonary edema. Look at those vessels which are engorged with blood. I'll show you another example. This is early pulmonary edema, where you have interstitial thickening, so that's edema of the pulmonary interstitium, and the vessels become a bit hazy. If untreated, this becomes much more severe, where you get alveolar edema, you get pleural effusions as well. Interstitial edema is where you have what we call septal lines. So these are these lines here, which is basically the edematous interstitium of the lungs, and they look like these horizontal white lines. They are actually thickened edematous interlobular septa. Here we have another example of septal lines. They can be overlooked as a busy x-ray, you've got a pacemaker, but if you look carefully you see these horizontal septal lines, thickened edematous interlobular septa, or septi. Here's the classic bat swing pulmonary edema, so it looks like a bat swing, sort of. You've got the airspace opacification surrounding both hilar. Bat swing pulmonary edema. And of course, if you treat the pulmonary edema, it tends to work. It tends to resolve fairly quickly, actually, compared to infection. This was a patient who had clearly had pulmonary edema. You've got the lines and tubes in the right place, you've got some cardiomegaly, you've got perihilar vascular engorgement, you've got interstitial edema, pleural effusion on the left, treated with diuretics, and you can see that the alveolar edema has reduced over the space of a day. The left pleural effusion is also reduced. Let's talk about non-cardiogenic pulmonary edema now. There are many causes which you can remember by the mnemonic not cardiac, which may or may not be helpful. The causes of non-cardiogenic pulmonary edema are near drowning, oxygen therapy, transfusion or trauma, CNS disorders, ARDS, aspiration or altitude sickness, renal disorders, fluid resuscitation, drugs, inhaled toxins, allergic alveolitis, contrast, reaction, contusion. And the distinguishing thing from non-cardiogenic and cardiogenic pulmonary edema is that in non-cardiogenic pulmonary edema, the heart size is often normal, so less than 50% of the width of the entire thorax. So here is non-cardiogenic pulmonary edema. The heart size is normal, but you do have this alveolar edema, this haziness around the hilar, basically. Here's a bat swing pattern of non-cardiogenic pulmonary edema. Again, look at the lines. The lines are in the right place. ET tube within the trachea, internal jugular line within the SVC, but you do have a bat swing, perihilar airspace opacification, but a normal heart size. The most common question we get asked as radiologists is how do we distinguish pulmonary edema versus infection? And very difficult, actually. I mean, ideally, you would look at the clinical scenario and see, if the patient's got a high temperature and a high white count, then it's likely to be infection. But if the patient's got a cardiac history, maybe it's pulmonary edema. Both have airspace shadowing. Infection is often lobar. Edema is bilateral and basal. Cardiomegaly and a rapid resolution after treatment favors edema. Infection takes much longer for the airspace opacification to resolve. So which one of these is pulmonary edema? The one on the left or the one on the right? Easy, it's the one on the left, isn't it? Because you've got the cardiomegaly, you've got sort of haziness around both lungs. Whereas one on the right, you've got a really clear, distinct lobar pneumonia, right upper lobe. You will come across pleural effusions fairly frequently in a hospital setting. Pleural effusions are the accumulation of fluid in the pleural space. That fluid could be blood, pus, transudates, or exudates. The causes are heart failure, upper GI surgery, pulmonary emboli, cancer, trauma, or pancreatitis. You actually need quite a lot of fluid to see it on a chest x-ray. So if you see a pleural effusion on a supine chest x-ray, there's at least 500 mils, half a litre of fluid in that pleural space. Let's have a look at a few examples. The appearance actually depends on the position of the patient. Fluid accumulates in the dependent areas. So for example, the patient on the left is upright. There is a right-sided pleural effusion. You can see the meniscus of that fluid. It's all accumulating within the dependent portion of the right pleural space. Now, this patient on the right has bilateral pleural effusions. Looks completely different to the X-ray on the right, on the left. Sorry, but the reason is because this patient has an X-ray taken supine, so lying down. So what happens is that the fluid in the pleural space just layers posteriorly. It's more at the bases, but it's spread upwards. So you get this sort of almost a sort of gradient of opacification, dense at the bases and then less dense in the mid zones, and this is what you call supine pleural effusions. Here you can see the density gradient. Supine effusions are much more difficult to diagnose. They're dense at the bottom, the pleural, the diaphragm is no longer clearly visualized because there's fluid around it and the silhouette sign has gone, and you can see this gradient. The upper lobes aren't that dense because the fluid hasn't actually layered behind them. What do you do with pleural effusions? Well, actually, if big enough, they can lead to respiratory compromise, and you may have to drain them. And we actually do that in radiology. We do ultrasound guided drainage. We put a little probe on the chest wall, make sure that the heart is out of the way and we're in the right place, and we put these drains in and drain, or even aspirate for diagnosis. This is an example of bilateral pleural effusions. You can see the sharp cardiophrenic angle is lost. It's actually blunted, and you've got this sort of meniscus type configuration of fluid accumulating within the pleural spaces at the bases. This is a lateral pleural effusion. You can see there is this line here with density outside, and that's just fluid within the lateral pleural space pushing the lung inwards, and the lung is the more translucent or darker area, and this is a lateral pleural effusion. The right hemidiaphragm is no longer visualized because you've got pleural fluid around it. There's massive cardiomegaly you can see. And well done to all those who spotted that the nasogastric tube was in the right place going below the left hemidiaphragm, and the endotracheal tube, which is here, is also in the right place. So let's talk about other airspace opacification, and one that we are seeing actually more now because people who had minor symptoms are presenting now, having not seen their doctors for a couple of years because of the whole pandemic. Is bronchogenic carcinoma. So here is a chest x-ray. Here is a large lesion obscuring the aortic knuckle, so a left upper lobe lesion. It's well defined. It's not fluid. It's not infection because it's too well defined, isn't it? You know, infection isn't this well defined. Look how demarcated the lateral aspect of it. This is a bronchogenic carcinoma. The best way to diagnose is to help diagnose is to look at old X-rays and see whether, firstly, if the patient has old X-rays and see how quickly this has developed. I mean, lung cancers do not grow as quick as infection. So you know, if it wasn't there in the week before and now you've got this mass, it's not going to be a cancer. It must be something else. Correlate clinically. Smoking, hemoptysis, has there been weight loss? If you see this, you have to confirm it with a CT, and then you got to get a sample of cells for the histopathologist to analyze, confirm your diagnosis, and tailor appropriate treatment. And biopsy can be done via bronchoscopy or CT, and radiologists do CT-guided biopsies of lung lesions. So this is like the lung cancer we saw before, but there's lots of them, so well demarcated soft tissue lesions throughout both lungs. These are cannonball metastases, so multiple lung metastases. Again, don't look like infection, don't look like effusions or pulmonary edema. Other patterns, this is what we call a miliary pattern, which essentially means lots of tiny nodules throughout both lungs, and the differential includes miliary TB, particularly if the patient is unwell. Thyroid metastases can look like this. Sarcoidosis can also look like this, but it all depends on the clinical picture. So if the patient is unwell and septic, it's likely to be miliary TB. This is a cavitating lesion. It's a cavity within the lung. You've got this rind of soft tissue, and centrally you have this airspace. Cavitating lesions are often caused by infections such as TB or aspergillus, but cavitating squamous cell carcinoma should always be considered. We should get a CT if we see this and consider a biopsy. Here is another example of a very small cavitating lesion, TB or cancer. Okay, so let's do some real-life emergency cases now. Are you ready? First case. You're an A&E. A 23-year-old male comes in, suffering a stabbing, short of breath, rapidly decreasing O2 saturations. In front of your very eyes, you can see his O2 sats go from 95 to 85 to 75, and they're just getting lower and lower. What's your diagnosis? Have a look at the chest x-ray. Use symmetry as your tool. There's obviously a difference between left and right sides. This one you can see air spaces, you can see lung markings all the way out to the end. But on the right, you've got this really dark area with no lung markings and a really dense area centrally. That is actually a collapsed lung. And this air within the pleural space is a pneumothorax. This can rapidly become a tension pneumothorax, which is a medical emergency. In fact, it's such an emergency that if you get a chest x-ray of a tension pneumothorax, you've managed the patient incorrectly, because you should have popped in a drain into the chest before a chest x-ray was ever taken, because taking a chest x-ray can take some time, and in that time the patient can die. So this is a tension pneumothorax. You can see the asymmetry of the lungs. The left pleural space is now full of air. The left lung has collapsed to this little nub in here, which really pushed it down. But what gives it away is this mediastinal shift. There's a tracheal deviation and a mediastinal shift to the right. This is tension pneumothorax. Next case, chest pain. This is a 53-year-old lady who's had a previous history of breast cancer, has come in with severe left-sided chest pain. All the cardiac investigations done in A&D were normal. She's not having a heart attack. What is the abnormality on this chest x-ray? Again, use symmetry as your tool. Nothing really going on in the right lung, but we know there's left-sided chest pain. Where is the abnormality? It's here. What is this thing over here? This is actually a rib. Why does it look so conspicuous? Because it's dense and it's expanded. What causes rib density? Sclerotic metastases. This is a sclerotic metastasis of a left rib causing left-sided chest pain. Trauma, patient fell off a bike. What's the abnormality? There's the pleural space. It's nice and sharp and crisp, so there's no pleural effusion here. Here's the lung. Here's the left heart border. There's no infection. The left heart border is very, very sharp, so there's nothing going on there. This is air within the fundus of the stomach. Can anyone spot the abnormality? Rib fractures. Can you see that cortex? And then you can see a discrepancy. No pneumothorax though, which is great. How about this next patient? Epigastric pain. We know this patient is 63 and a male, has rheumatoid arthritis, which is relevant, I'll tell you why. And he has epigastric pain. What's the abnormality? Okay, there's the lungs. possibly a bit of infection here. This is the right hemidiaphragm, this is the left hemidiaphragm. What we're seeing is a huge amount of air underneath the diaphragm. So this is air under the diaphragm, which means that the patient has perforated a hollow viscus, probably stomach or duodenum. Patient's got rheumatoid arthritis or might be on steroids, or actually NSAIDs, which increase the risk of perforation. Next patient. Sorry, these are arrows showing the hemidiaphragms. Next patient is a patient with chest pain, severe vomiting, sudden onset chest pain. Diagnosis: look at all this streaky air in the mediastinum. You've not seen something like this before. Really sort of streaky around the mediastinum. All this soft tissue and air, not air bronchograms because they're longitudinal, aren't they? They're not conforming to a branching air bronchogram. This is air in the mediastinum. This patient had severe vomiting. He's ruptured his esophagus, and air within the esophagus is now escaping around the mediastinum. What's going on here? Where's the asymmetry? Top marks for those people who saw this very, very dense object within the right main bronchus. It's so dense, isn't it? It's even more dense than bone. What do you think this is? What's more dense than bone? Metal. What kind of metal object is this? This is actually a crown of a tooth, which somehow has got loose and the patient has inhaled it, and it's basically sitting here lodged in his right main bronchus, and unless it's treated and removed, this patient's going to get a very, very severe infection into that right lower lobe. Inhaled foreign bodies. Look for densities that are not densities that are normal for the thorax. I do feel that it's necessary to give a special mention to the chest x-ray when it came to the diagnosis of COVID. Now, it was incredibly important, the chest x-ray during the pandemic, because we needed to diagnose COVID quickly, because we needed to treat these patients quickly, and we needed to isolate these patients as soon as we knew they had COVID. The PCR tests used to take a day, and they were not good enough. We didn't have a day for a highly infected patient to infect everyone on a ward or everyone in their community. So we actually relied on the chest x-ray. And the chest x-ray was really important in COVID because COVID had very distinctive features on a chest x-ray and became the mainstay of COVID diagnosis. COVID on a chest x-ray shows up as peripheral ground glass airspace opacification. So you can see these very subtle ground glass type opacities mainly within the periphery, sparing the upper lobes, hardly ever associated with pleural effusions. And we use this all the time to diagnose COVID. When we were in hospital, we dropped everything and just concentrated on A&D x-rays, so we could tell our A&D colleagues which one of their patients had COVID, which ones had to be isolated, and which ones could be sent home. So chest x-ray was one of the most important medical tools in the diagnosis of COVID in the last 2 years. Anyway, thank you so much for listening. This is going to be on Google Drive, and we will get the link sent for those who want to review the lecture, look at the chest x-rays, and once again, thank you for listening.